You know, staff and patients have absolutely loved this technology. When we first got this machine, our staff was initially a little apprehensive. Obviously, anything new is usually met with some resistance. But within a month of us purchasing our first unit, they begged us to buy another one. So after a month, we had 2 OPD scans. And the staff have loved the fact that it's a one-stop shop for all of the tests that we need to do to work up a cataract patient, a LASIK patient, and just pretty much even just a regular new patient that comes in. We get topography, we get K readings, we get aberration profile. We can tell where their astigmatism is coming from. Is it from the cornea? Is it from the lens? So we get a lot of information real fast, and it's all done in one station. So patients like it because they don't have to go from room to room. They get quickly to the doctor. Staff loves it because obviously it's a lot more efficient, and the patients really like the fact that we can actually show them on a screen exactly what we're looking at. So a picture is worth 1,000 words, and we can really help them understand the concepts a whole lot better by showing it to them on the computer screen. As far as the use of the OPD for premium IOL patients, I went through a few different examples of broad ways that we use it. And you know, specifically, I had a patient just a couple of weeks ago who had a crystal lens implant put in. He came in on his 1-week visit, and he was 20/20 doing well. At his 1-month visit, he told me that his vision had declined, and we did an OPD, and it showed a diopter and a half of astigmatism, which wasn't there previously. So as I studied the OPD, I found that the astigmatism was actually not present in his cornea, but it was showing up internally, which presumably was from the lens. And so the thought that went through my mind that maybe this could be the beginning of what we call a Z syndrome, where the crystalline starts to fibrose in an abnormal way. We dilated the patient, and it was initially hard to see. If I didn't have the OPD to kind of tell me, to clue me in on this, I probably would have missed it. But after a thorough exam, after we got them really well dilated, I was able to tell that there was a little bit of a tilt in the IOL. And that really changed how I managed it, how I managed this patient. If I didn't have that information, I hadn't seen the tilt, I probably would have ended up doing LASIK on this patient. But you know, within the first month or two, we have the opportunity to go back in and reposition the lens and put a capsular tension ring in, which is what we did, and that resolved the astigmatism and solved the problem. So I think the OPD really helped guide me in that direction, and I probably would have faced some challenges if I had not had access to that information. And you know, we do a lot of premium IOLs. We do the multifocal IOLs, the toric IOLs, and we also do the crystallines. And so the OPD has become an integral part of our process in taking care of these patients, both for preoperative care and also postoperative care. So when the patient first comes in, we do an OPD on all of our cataract patients, and I'm able to tell how much astigmatism they have, how much is coming from the cornea versus the lens. That helps me determine whether they're a candidate for a toric lens. We look at their angle kappa, which helps us determine whether they do well with a multifocal lens. Also, we look at the aberration profile, which is an extremely critical part of our workup. And the OPD does a good job of splitting it between the cornea and the rest of the eye, which is mostly the lens. And so if a patient has a high degree of aberrations in their cornea, I'm not going to do a multifocal lens. If the aberrations are coming from the lens, then obviously we can take care of that with cataract surgery, and they'd be a good candidate for pretty much any of the lenses. So preoperatively, it's extremely helpful in isolating the particular lens that suits that given patient, and so we can customize our care. Postoperatively, it's extremely helpful as well. If I have a multifocal patient who's not happy with their results, I can quickly run a scan and see what's going on. I can see if there's an aberration that's coming from the cornea. If so, then that's obviously interacting poorly with the lens, and we might do an IOL exchange. If the aberrations are present in the lens itself, that might be a reason to do an IOL exchange as well. With our crystal lens patients, sometimes people will get a little bit of a tilt with the lens as they heal. The crystal lens is it's flexible, and so if you get some fibrosis that's asymmetric, you can get a little vault of the lens or a little subtle tilt of the lens. With the OPD, I can quickly determine if they have astigmatism, and if they do have astigmatism, where is it coming from? If it's in the cornea, I take care of it by doing LASIK or PRK. If the astigmatism is actually coming from the lens and they have a crystal lens, I'm going to be looking for a tilt in the lens. Sometimes it's very subtle, and because I've been clued into it by the OPD, I know I need to look really closely for that. So obviously if the lens is tilted and I do LASIK, I haven't really fixed the problem. So for those cases, I'll go back in and reposition the lens. For my toric patients post-operatively, it's extremely helpful in looking at the position of the lens, obviously, but also without dilating them, I can get a profile of their astigmatism. I can see how much of their astigmatism has been corrected with the IOL. And I can show the patient, what their corneal astigmatism is. If it's a bow tie at 90, the OPD, if the toric IOL is well aligned, will show astigmatism in the opposite meridian in the same magnitude, so a patient can actually see how we're correcting their astigmatism. So pretty much for all the premium IOLs that we use, it's really an important tool that we use for both our preoperative testing and screening and lens selection, and also postoperative management of issues as they come up. So as far as determining the position of the IOL after surgery, and that's of critical importance with the increase in the premium IOLs that we're doing. When it comes to the toric lens, it needs to be in the right orientation, the right axis. When it comes to the multifocal lenses, they need to be well centered on the visual axis, not necessarily in the center of the cornea. And the crystal lens also needs to be well centered without any tilt. So the OPD really helps us by answering where is the lens in the pupillary axis, is there a tilt, is the toric lens well aligned. We can actually see the marks of the toric lens on the retroillumination picture of the OPD. We can also just indirectly kind of assess where the lens is by looking at the numbers that the OPD is giving us. So if we can get a measure of the degree of astigmatism that exists in the lens and what axis it's at, that'll give us an idea as to whether the lens is properly aligned. So for multifocal patients, if the lens is out of position, if it's not centered, you'll get higher degree of aberrations, higher order aberrations, which are internal versus in the cornea, and that'll clue me in to pay particular attention to the position of a multifocal. So regardless of what premium IOL I'm using, the OPD really helps me determine where the lens is, whether it's in the right place, and if I need to do any adjustments. So there is an interesting phenomenon that occurs in many people where their prescription fluctuates during the day. So they might have a different prescription at night as compared to during the day. And this is mostly due to the size of their pupil. So during the daytime, when the pupil is smaller because of the lighting, you might have a given prescription or a given refraction. You might get a myopic shift with even some astigmatism perhaps at night. And so we've had challenges fitting glasses for patients because they'll tell us that their glasses work sometimes, but they don't at other times. Also for us in our practice, the most important thing that we see is that LASIK patients will sometimes come in asking for us to do an enhancement of their LASIK because they feel like they're not seeing as well as they need to at night when they're driving. When I do an OPD, it actually gives me a refraction under scotopic conditions, mesopic conditions, and photopic conditions. So I can kind of see if there is a difference in their refraction based on their pupil size, based on the lighting around them. And if I'm getting, for example, myopia under mesopic conditions when their pupil is bigger, but during regular, in regular situations, their prescription is close to plano. If it's a LASIK patient, I'm not going to do an enhancement on that patient. I'll just give them some night driving glasses. For patients, non-LASIK patients who are having trouble with glasses, sometimes I'll give them more than one prescription, one for nighttime driving and one for the day. So, the OPD really helps us accomplish this because it gives us very accurate autorefractions, and it also gives us that distinction between mesopic and photopic conditions. So it helps us really help our patients in a way that we weren't able to do so before. So the OPD-3 has really helped us increase our efficiency and reduce patient wait times. And it really does have a significant wow factor. Patients come into one room, one station, and they get their autorefraction, they get their keratometry, they get their aberrometry, they get their corneal topography. And with the EPIC, they get a pretty good refraction as well. For our cataract patients and for our patients who are pseudophakic, we get a good BAT test as well with the EPIC. And so it really does replicate real-life situations, I think, way better than our previous waves of testing for glare impairment. And so you can get that all in one place. And so what this has led to is it's led to obviously better flow through the clinic. When you have to go to one room versus 5 different rooms for all these tests, it really helps increase our efficiency. It's also really helped the patients understand what we're talking about, because now we can actually show them what all these nebulous terms really mean on the screen. So we've incorporated this into our EMR system, and when a patient walks into my room, the OPD is on our computer screen. I can talk them through every part of their eye and really discuss with them why their vision is poor. If they have a cataract, I can actually show them the cataract. You can get a retroillumination view of the cortical spokes or the posterior subcapsular cataract, and that's really nice to show the patients, because then they can see why they're having those glare issues, why the lights are blinding them at night. And so, again, a picture is worth 1,000 words, and the pictures that we can show patients, I think, really do impress them. And when the patient gets the sense that we've invested in this high level of technology, and they can see it for themselves, I think it adds their confidence in us as doctors in our practice. And when we're asking them to invest a significant amount of money for these presbyopic correcting lenses, for example, they need to know that they're going to a place that knows what they're doing and that has invested in the appropriate technology to optimize their outcomes. And I feel just having this tool available to show them the results of their exam helps us to educate them and helps them to feel more confidence in us as a practice, knowing that we've invested in technology that really helps us make a difference.